Welcome, everyone, to the National Action Alliance for Patient and Workforce Safety. We're delighted that you're able to spend your morning or afternoon with us. We're joined on the line today. We'll have about, we have 600 or so registrants for the call, and we see that there are people calling in from all across the country, including the Ohio State College of Nursing and folks from Chicago and New York. We want to just welcome you warmly. Next slide, please. A few housekeeping notes. As a reminder, this webinar is being recorded and will be available for viewing on the National Action Alliance website. We would love for this to be an interactive session with so many people on the line. We would ask that you use the chat function, and we will work to include your question or comment throughout the presentations today. For those that may need closed captioning, it is available in the lower left-hand corner of your screen. Next slide, please. For today's presentation, we have lined up experts from across government, and we have special guests today as well. But the questions that we're running on are, how are we partnering with federal agencies, private partners, healthcare systems, patients and families, and others to achieve the aims of the National Action Alliance? And then how will we collectively share information, promising practices, and lessons learned through this learning system? Next slide, please. Back one. Thank you. One more. One forward. Great. With that said, I'd like to turn the floor over to Dr. Robert Valdez, the Director for the Agency for Healthcare Research and Quality. Dr. Valdez, the floor is yours.
Good afternoon and welcome. I'm Robert Valdez, and I have the honor and privilege of serving in the Biden administration as Director of the Agency for Healthcare Research and Quality. On behalf of the Secretary Becerra and all of HHS, I welcome you to the National Action Alliance for Patient and Workforce Safety webinar series. In November 2022, Secretary Becerra launched the Alliance as a partnership effort with patients, healthcare executives, and members of the department to regain the ground lost in patient safety during the COVID-19 pandemic. He charged the department with regaining momentum and extending our efforts to ensure that patients are not harmed when they seek healthcare services. The Secretary also asked us to focus on the health and safety of our healthcare workforce, which was so affected by the pandemic. And as a reminder, the Alliance's vision is safe care everywhere and zero preventable harm for all. And our patients and workforce are counting on us and our private sector partners to make sure that's the case. We must work together to achieve this vision. And the good news is that since the launch of the Alliance, we're seeing some improvement already, such as reductions in healthcare associated infections. 85% of hospitals have made some progress on at least one infection among the 3 that are tracked by our partners at Leapfrog. At this point, only about 15% of hospitals have not made progress, and there's opportunities for progress in many of the other settings in which care is provided. This is a good start, but obviously more work together must be done to achieve the goal. We must remain urgent in addressing patient and workforce safety. That urgency is something that so often gets lost when the crisis abates. But we must be urgent if we in fact want to address patient and workforce safety to better serve the needs of our families, our neighbors, and our communities, and to push towards our milestone aim of a 50% reduction in patient and workforce harm by 2026. The National Webinar Series is designed to be a space for learning, information, engagement, and building momentum for action. Everyone passionate about health and well-being of patients and the workforce is welcome to join these webinars. We need advocates with action-oriented mindsets to implement steps to ensure that we have safer care everywhere. To that end, In the coming months, this series will feature topics that will help organizations solidify their foundation for safety. We'll highlight different tools and resources, including funding opportunities that may support you in your efforts. Today, I'm joined by a great group of speakers to kick off this webinar series. First, you'll hear from AHRQ about a broad overview and progress update on the National Action Alliance since last fall. Then our colleagues at CMS and CDC will present an update on their agency's work related to safety and alignment with the Action Alliance. And also on today's call, we have a healthcare safety champion sharing their experiences and perspectives on patient safety moving forward. I want to thank you all for joining us today and for all the work that you do daily to make healthcare safer. I'll turn this call over back to Jade.
Great. Thank you so much, Dr. Valdez. We're grateful for your leadership and for taking time out of your busy schedule to kick us off today. Next, I would like to turn to our very special guest, Vonda Vaden Bates. Mrs. Bates is on the governance board of the Patient Safety Movement Foundation. She's a public speaker and a patient safety advocate. She began campaigning to improve communication and safety in healthcare after extensively researching how her late husband passed from a common preventable cause of hospital death. We're very grateful for your time today, and I'd like to turn the floor over to you. Thank you.
Thank you so very much for having me here today. I wish that it were under some different circumstances, of course, and I also just want to acknowledge all of the patients and family members and care providers who step forward as I am about to tell about the experiences and the impact of a very, very dire situation with regard to safety in healthcare. I'd like you to meet my husband, my late husband, Yogiraj Charles Bates, to the best of your ability. He had a small insidious brain bleed that required a craniotomy in a hospital about 12 years ago. And his brain bleed was fixed. He went into the hospital for that reason, but he died because of complications. And specifically, he died from a hospital-associated venous thromboembolism. Next slide, please. I'd also like you to meet our family. This is our merged family. We married in 2009. And this assembly is just one assembly of probably hundreds. I don't think that it is an exaggeration at all to say that someone misses him every single day and has for the last 12 years. It's coming up on 12 years this June. Next slide. My husband was an author, grandfather, terrific husband, father, brother, uncle, and he really spent his life dedicated to helping others be their best selves. And as you'll hear from me in the next 10 minutes, it is my belief that part of his philosophy of life might help us today in this very moment as we all unite to support safer care everywhere. Next slide, please. Clinicians often ask, what happened? And I don't have time to get into all of the details, although I'm certainly happy to do that if there's anyone who wants more information. But in short, he did go in for the brain bleed. He had a craniotomy that was fixed. And then over the course of 12 days, with 8 different hospital transitions, he developed symptoms of both DVT and PE, including pain in his lower calf, a fever, elevated D-dimer, and sudden chest pain. Sometimes those chest pains would last with anxiety for hours following, periodic labored breathing, low oxygen saturation, and this often complicated his ability to complete physical therapy. He collapsed a couple of times due to probably small PEs, which were indicators that that was occurring. Ultimately, tonic-clonic seizure was the final symptom of his PE before he died back at ICU with a hospital-associated venous thromboembolism. Next slide, please. We could see several, or I guess we would say we didn't see. There were a number of blind spots, I think, on our part as patients and family members, as well as on the individuals in that hospital. And I do want to preface it by saying that that third piece, number 3 on this list, is the one that stands out for me the most. He received very kind care. We definitely confused that kind care with safe care. We did not recognize at that time that there were such things as hospital-associated events that could happen. We were not looking for those things, and there was no information given to us about those things. There was an exclusive focus, I think, on his brain bleed, which then kept deferring everything back over to neurosurgery. But from their perspective, they had done their job quite well, and they were not seeing any indicators that there was any issue with that. There was very little to no focus on the other kinds of complications that could have been happening and indeed were happening, such as DVT. There was a tremendous amount of passing off of accountability. You can see it in the medical record. We could hear it a little bit every once in a while, a little bit of an argument here or there. I think where it became most evident to me was after his death, when I returned to that hospital to try to make sure that what had happened to him was not going to continue to happen to others. Next slide, please. Where I would like to make sure that we stay engaged here today, all of you, me, our family, who gives me permission to speak about these experiences which have so deeply touched our lives. And I want to give you a symbol of something that worked very well for my husband and I hope may work well for our work here together with the National Action Alliance. And I'm just so pleased that this organization has formed out of AHRQ so that we can take an approach that factors and respects each and every individual who is providing care, each and every individual who is receiving care, and all of us who support on the periphery in the various ways that we do. When we were married, if you go to the next slide, and then I'm going to have you go back to this slide if you don't mind, please. Go one more slide. I think you'll see. Yes, this is the gift from my husband on our wedding day, and it is a symbol of something that we called our we. There was him in our marriage, there was me in our marriage, and there was this we, and we thought of that we as an entity that required its own care, and that care was different than my care, and it was different from his care. If you go back one slide, please. We personalized this, we symbolized it with that and many other symbols, and that energized us. And so when times were hard or difficult and things got complicated, we would remember that we as an entity, and we would step forward to do the things that we needed to do to care for that. And go back one more slide, please. So I invite you today to really think about your why. The we is our why. The we, for me, is my why I stand here or sit here with you today. And I would invite you very much to think about how it is that you will be motivated beyond today's seminar, beyond when you get back to work and you're working with the folks that you do on behalf of the healthcare that you provide in the systems that are attempted to design for safety. The policies at a hospital level, a clinic level, at a governance level that are attempting to try to create safe care. Why do you participate? What is your why? And I think Jade is going to come back in and invite everyone to put that in the chat.
Yes, thank you. And you can enter your response into the chat. You know, what is your why? Please help us show Mrs. Bates our appreciation for sharing her story with us today and keeping the focus on the patient. I love what you said about the we as its own entity, and then what a wonderful reminder that is for us on so many levels. But we would love to hear from a few of you today. If you would enter your response into the chat, we'll collect just a couple of those before we move on.
Thank you. I appreciate that. And just in case I didn't say it precisely, like I do have a belief in the work that is happening here, that when we come together and I'm not saying we replace our individual or our organizational priorities. We need to silo sometimes in order to stay focused, but we also really need that capacity to take that and set it aside for a moment and really consider our interconnectedness. And here I'm talking about policymakers, the device manufacturers, the process-oriented folks, the quality and safety officers, the board members, the patient members, the patient and family engagement members like me, and so many people that I've met over the last 12 years who have taken an experience that feels so unacceptable and so preventable and tried very, very much, continue to try very, very much to convey that this is important. It demands our prioritization and our budgeting. All of the things that we need to do to pull together here forms that we for me. And I'm just so grateful to these efforts that you are individually making and the efforts that every one of us here today is making in our various assemblies. And I do think it will make a difference. And that is my why. And I will very much look forward to coming back and reading your whys. I hope we'll be saving this chat.
We will, and we would love to share it with you. And I'll just, they're coming in kind of fast right now, but lots of thank yous being expressed. And one note here, my why is the alleviation of unnecessary harm. Some more thanks, advocating for those who don't know how to advocate, alleviation of unnecessary human suffering. We're seeing comments about feeling very strongly about what every patient how every patient should be treated exactly as we would want our own family members to be treated if we could care for them ourselves. Thanks you for sharing her story. Let's see. A faith-based commitment to love thy neighbor and dedicated to protecting patients in whichever role that they're currently in. At a minimum, healthcare should be safe healthcare in a healing environment where harm has no place. I think that's the perfect one to end on, but we'll be sure to share the full list with you, Mrs. Bates. Thank you again for being with us today.
Thank you so very much.
Sure. And now I'd like to turn things over to Dr. Umscheid, Director for the Center for Quality Improvement and Patient Safety at AHRQ.
Thank you, Jade. And I just wanted to take a moment, Jade, to thank you and Melissa Botnegger and the entire team for helping us lead this National Action Alliance for Patient and Workforce Safety at AHRQ, and on behalf of HHS and our sister agencies. I think this webinar that's starting off our webinar series is just one of many examples of how you and Melissa and the team have gone above and beyond. So I really appreciate it. I also wanted to thank Miss Vonda Vaden Bates for her presentation. I'm really happy that we started this presentation off with a presentation from a family member because it reminds us that patients and families need to be at the heart of our patient safety actions. And all that we do is clearly directed toward the needs of patients and families and their health needs. And so it's a good reminder that patients and families really need to be at the heart of these discussions and presentations. You could go to the next slide. I feel fortunate to be directing the center AHRQ that's focused on patient safety. And as Dr. Valdez shared at the top of this call today, Secretary Becerra did have a call to action and a recommitment to patient safety on behalf of the healthcare community back in November 2022. And as many of you know, this was a result, as Dr. Valdez shared, of the increase in patient safety incidents that we saw during the pandemic. And as the public health emergency was coming to an end, there was a strong thought that we could recommit to patient safety and drive those safety incidents down from the peaks that we saw during the pandemic. Earlier this past calendar year in March 2023, our National Advisory Council at AHRQ, which is essentially our board, charged a subcommittee of healthcare experts from the community to provide us with recommendations, us at AHRQ and HHS, on how we should go about best supporting and facilitating a national action alliance directed toward improving patient safety and healthcare workforce safety. That subcommittee met during the fall and came up with their recommendations in December 2023. And we all have been working hard to operationalize those recommendations over the last few months. You could go to the next slide. These are the 5 aims that have come out of the subcommittee's work. So this is the 5 aims of the National Action Alliance for Patient and Workforce Safety. And I'll take just a minute or two to go through these 5 aims and the figure that you see in this slide. So the first aim is to advance healthcare organization safety strategies using safety self-assessments. So what we're asking healthcare systems is to make a commitment to the National Action Alliance to perform safety self-assessments and enact safety strategies based on the gaps that are identified through those safety self-assessments. And you can see in the figure here that that's really the overarching aim of this National Action Alliance. The second aim is to empower the patient's voice in safety strategy. And I saw a couple of comments in the chat around how at some level the patient and the healthcare team are separate entities. And you could imagine, as Ms. Bates was saying, that there's also a we, and that we comes about not just from a relationship built on a marriage, but also a relationship built on clinical trust and a clinical interaction. And so empowering the patient's voice in safety strategy is a critical aim of the National Action Alliance. The subcommittee laid out a number of different ways that we could do this, from enabling patients and families to be able to submit safety concerns directly into patient safety incident systems within healthcare settings. Oftentimes that's not the case currently, that's available to patients and families. Patients and families being included in patient safety event reviews for those events that they submit. Patients and families providing input on safety initiatives, and healthcare systems making a commitment to implement communication and resolution programs such that medical errors are disclosed in a transparent way to patients and families, such that those errors can be addressed and better understood. And the patient's voice in this figure is represented as a central point in the figure, as you can see. The third aim is making healthcare safer by design. And the subcommittee recommended that we identify and address 5 high priority safety engineering needs that we could tackle in the coming years. The fourth aim is to strengthen safety competencies. And this isn't just about safety competencies for the safety workforce or the quality workforce, but this is the entire healthcare workforce, from the board, to administrators, to clinical and non-clinical staff. And the fifth aim is to launch a learning and research network to encourage learning and sharing across the network, to spotlight change leaders, to promote robust measurement of safety across systems, and to support research to address high priority safety needs. And that learning and research network is represented as the foundation of this work in the figure. Next slide. One approach that healthcare systems can use to perform safety self-assessments is using the safety self-assessment offered as part of the 2020 National Action Plan for Safety. As some of you may know, the National Steering Committee for Safety put out this 2020 National Action Plan for Safety. It came out in the start of the pandemic, so didn't get the traction that we would have liked to have seen. It came from the National Steering Committee, which was made up of about 30 national organizations and was co-chaired by AHRQ and IHI. And the National Action Plan set forth foundations for safety at the healthcare system level. And you could see those 4 foundations in this slide here. And the National Action Plan came with a self-assessment that healthcare organizations could use to ensure that they were identifying opportunities for improvement in each of those foundational areas. And as an example, you see the first foundational area, culture, leadership, and governance. 2 of the many self-assessment items in that foundational area are things like, do leaders have annual reviews that incorporate safety? Does their healthcare system have regular safety culture surveys? For the second foundational area, patient and family engagement, there are self-assessment items like, does the healthcare system have actively engaged patient and family advisory councils? Does the healthcare system analyze data using an equity lens so that it can understand if safety is different across different populations and address those potential inequities? For the third foundational area, workforce safety, there are self-assessment items like, does the healthcare system have explicit worker safety strategies or occupational safety experts? And for the fourth foundational area, learning healthcare systems, does the healthcare system have defined safety competencies for all of the healthcare workforce? Do they regularly participate in learning networks? Next slide. So when a healthcare system and a healthcare setting performs a safety self-assessment, that's really the start of this process. And you can see on the bottom of this slide starts with identifying safety needs through a baseline safety self-assessment. And then the hope is that healthcare systems can draw on resources provided by our National Action Alliance engine to help them address gaps that they've identified in their safety plans. This National Action Alliance engine is built of resources that come from our partners across Health and Human Services, including AHRQ, CMS, CDC, and many others, and also resources from beyond the Department of Health and Human Services and beyond the federal government. And the resources included in this National Action Alliance engine include items like learning national webinars, implementation initiatives that are supported across the country at no cost, various toolkits that are available to address identified safety needs, funding opportunities to support safety research, and measure sets, and a national safety dashboard, which I'll talk about shortly. And the hope is that learning healthcare systems can draw on this National Action Alliance engine and the resources within this engine to help them identify and implement best practices, to help them learn from those who are part of the National Action Alliance network, to help identify sources of support for research. And all of this work aligns with value-based payment and care that's being supported by CMS and private insurers across the country. And the hope is that by 2026, this activity will help us reduce harms in half and ultimately help us realize our vision of safe care everywhere, zero preventable harm for all. Next slide. This slide just provides examples of some tools, funding opportunities, and implementation initiatives that are coming from AHRQ. But on our website, there are many opportunities from AHRQ and our sister agencies like CMS, CDC, and others. In this slide, these resources are organized by the National Action Plan for foundational areas for safety. So for culture, leadership, and governance, at AHRQ, we provide surveys on patient safety culture. For the patient and family engagement foundational area, we provide Team Steps 3.0, which is training around communication between the team, but also between the team and patients and families. We have a revised Team Steps tools, Team Steps 3.0, that was recently released, and we have an implementation initiative that just kicked off this month and is going for the next 6 months, where healthcare systems and individuals can engage in virtual and in-person training on the new version of this tool. For the Workforce Safety Foundational area, AHRQ has a brand new funding opportunity, the first of its kind at AHRQ, where we're supporting patient safety by improving healthcare worker safety and well-being. And for the Learning System Foundational area, we have the AHRQ Patient Safety Network, which is a one-stop website for resources to support patient safety. We also have measure sets like Calibrate DX, which can help improve diagnostic safety at the healthcare system level. Next slide. This slide is just an example of how our National Action Alliance for Patient and Workforce Safety aligns with so many other critical efforts that are being supported across health and human services. This is, as many of you may know, a proposed patient safety structural measure from CMS. It could start as early as next calendar year. And this safety structural measure would ask healthcare systems to attest to the items under each of the domains. In this slide, we show the first 3 of the 5 domains in this safety structural measure. And this gives you a sense of how closely aligned we are across the federal government around our efforts to improve patient safety. So you can see in domain 1, leadership commitment to eliminating preventable harm. One of the specifications is the C-suite oversees a safety self-assessment and builds a plan based on that self-assessment and metrics based on that plan. For domain 2 around strategic planning, you could see the first item, strategic plan publicly shares a hospital commitment to zero preventable harm. The first item in domain 3 around culture of safety and learning health systems, the hospital conducts hospital-wide culture of safety surveys. So very close alignment between our initiatives across the government to support patient safety. Next slide. One of the initiatives that we're working hard to stand up this fall is a national healthcare safety dashboard where we can track all of the different safety measures that our organizations have put out over the years and understand where we're making progress and where we need further improvement. In this example, this is a mock-up. You can see that on the dashboard we have safety measures for different healthcare environments like the emergency department, ambulatory care, nursing homes, and hospitals. In this specific example, we're focused on hospitals, and you can see different measure sets located within this mock-up, like measures around healthcare-associated infections or patient safety indicators, measurements specifically focused on the Medicare population, patient experience, culture of safety. And you can click on each of these measure sets and gauge our progress on safety for those measure sets. So in this example, we're looking at the patient safety indicators, and we're looking at a particular patient safety indicator, postoperative sepsis. And you can see how postoperative sepsis, the rates are improving over time from 2016 to 2020. And we're able to stratify these measures by variables like race to understand if there are differences in performance across populations. Next slide. This is the commitment that we're making. We're asking healthcare systems to make, to commit to the National Action Alliance for Patient and Workforce Safety. We're trying to minimize any barriers to entry because we really want all healthcare systems to join us. Healthcare systems that have been doing this work for years and years, and those who are newer to this type of work, where we can all learn from the strengths that each other has around patient and workforce safety, and also where there are opportunities for improvement. And you see the commitment is highly aligned with the aims of the National Action Alliance. So the first commitment is to champion patient and workforce safety by designating an executive lead accountable for safety at the organization. The second commitment is to perform an organizational safety self-assessment. The third commitment is to empower patients' voice in all aspects of safety across the healthcare setting. The fourth commitment is to strengthen safety competencies for all team members. And the fifth commitment is to collaborate when it comes to safety by sharing lessons learned and using and contributing to safety resources as an active National Action Alliance participant. Next slide. So this is my last slide, and I just wanted to highlight that the National Action Alliance has a website to serve as a hub to foster engagement across healthcare systems and federal and private partners in this Action Alliance. On the website, you'll find safety resources that healthcare systems can use to address those safety gaps that they identify. You can also learn more about the National Action Alliance and also upcoming webinars. So with that, I'm going to pass it back to Jade.
Great, thank you so much. Next slide, please. Next, we're honored to have with us today Dr. Michelle Schreiber. Dr. Schreiber is the Deputy Director for the Center for Clinical Standards and Quality and the Director for the Quality Measurement and Value-Based Incentives Group at the Centers for Medicare and Medicaid Services. Dr. Schreiber, the floor is yours.
Jade, and to Craig, and to AHRQ for your leadership of the National Action Alliance. We're pleased to join this webinar today to highlight some of CMS's actions to improve patient safety. As hopefully you can see, we are all working across the federal government and in alignment with the call for safety action in the PCAST, the President's Council of Advisors on Science and Technology, to advance patient and workforce safety. We witnessed during the COVID pandemic that safety metrics declined, in some cases precipitously, especially in places like nursing homes and for vulnerable populations. In a New England Journal of Medicine article in February of 2022, CMS was one of the first organizations to call for a recommitment and refocus on patient safety because the underpinning systems of safety seem not to be durable or resilient. The good news is that we're now starting to see safety metrics improve, as Dr. Valdez noted, although not yet achieving pre-pandemic metrics. Next slide, please. Our quality and safety strategy is supported across CMS through our National Quality Action Plan and our strategy. This has been developed over the past 2 years and is a collaborative effort across the agency to focus and align quality and safety in all our areas: Medicare, Medicaid, the Marketplace, the Innovation Center, the Center for Clinical Standards and Quality, and others. As you can see, it has 8 distinct goals organized into 4 priority areas, with the patient and family at the center of all that we do. Goals include equity, engagement, including patients and caregivers, best outcomes, interoperability, advancing science and technology, and resiliency. Across CMS, we meet weekly to align our policies, priorities, and to evaluate our multiple levers to advance this strategy. And as you can see, safety with the goal of zero preventable harm is a key part of this strategy. Next slide, please. CMS is currently in the process of developing our 10-point strategy for safety. It's not quite ready for public release, but we have always been taking ongoing action to improve safety and reduce harm. Some of our key actions include increasing transparency to better inform consumers and to promote accountability for safety. CMS has over 27 value-based reporting or payment programs across all facility types and across the continuum of care. Most of these have safety metrics, and these data are reflected in multiple care compare websites, which provide public data on quality and safety and have associated STARS programs, which allow ease of comparison. We are currently evaluating how to best weight safety in these programs. We're driving improvements in safety through incentives and penalties, such as the Hospital Acquired Condition Program, and through quality initiatives, such as direct quality assistance from the QIO quality improvement organizations, and of course, through regulator oversight. We're promoting safety initiatives that protect the workforce, including the recently published and somewhat controversial nursing home staffing ratios and our conditions of participation, which ensure a safe working environment. And finally, we promote the safety and security of personal data and digital data exchange through our Promoting Interoperability programs, the mandatory exchange of digital data without information blocking, review of guidelines for safer EMR use, and in the patient safety structural measure, which Craig alluded to, ensuring patients have access to their records, such as through patient portals. We're also evaluating initiatives to support cybersecurity and the safety of artificial intelligence. Next slide, please. Some of the other highlights to promote safety include, as I had noted, the draft of the 13th Statement of Work for the Quality Improvement Organizations. This was recently released publicly, and we are now finalizing this in our 5-year commitment to the Quality Improvement Organization Network, which will include a focus on safety. I noted that there are some in the audience and participants from the QIO world. CMS has prioritized nursing home safety in response to the pandemic and has a national campaign to improve nursing home safety, including workforce awards to train more nurses and grow the workforce there. And on the other end of the age spectrum, CMS has a number of maternal safety efforts, including new maternal safety metrics, our birth-friendly designation, which recognizes hospitals who participate in ongoing quality improvement for maternal care, and implementing best practices. You can see the links in this slide. On the next slide, please. I've alluded to many of the levers CMS has to advance patient safety, all of which are being integrated into our cross-agency strategy. We are a leader in safety reporting and maintain a significant portfolio of safety measures, all of which are available to the public. We provide technical assistance through the QIOs, establish safety standards through the conditions of participation, and we have established policies on payment or non-payment for certain errors. Next slide, please. Our portfolio of measures includes safety metrics across the continuum of care, although most have been focused to date in the hospital setting. But you can see we have metrics across all settings. We've been evolving our measurement to transition to fully digital measures, electronic measures which capture the rich clinical information from electronic medical records. They are all payer, and ultimately, they are most efficient and least burdensome. Over the past several years, we have finalized a robust suite of electronic clinical quality measures for patient safety and measuring common harm. This year, in the recently released hospital law program, the IPPS, Inpatient Prospective Payment System rule, we've proposed new safety measures, including the patient safety structural measure that Craig referenced. We hope that you will take a look and provide your written comment. Your comments do matter, and I guarantee you everyone gets read. Next slide, please. Our other resources and tools include, of course, the conditions of participation, the Quality Improvement Organization assistance, as I noted, and our recent National Impact Assessment. This looks at the trends of many of our quality and safety measures. And in this particular report, it showed measures that were pre-COVID through COVID. And the next assessment, which will be done in 2 years, will complete the journey post-COVID. Our Quality in Motion update is our work across CMS on the National Action Plan and was made public just recently at the CMS Quality Conference. And our CMS Measures Inventory tool called CMIT is publicly available to all as well. In summary, CMS works closely with AHRQ, our other federal partners, including CDC, the FDA, NIH, Veterans Administration, ONC, the Office of the National Coordinator, to promote safety. We're committed to ensuring safety for patients and workforce, and we're fully aligned with the goals of the National Action Plan, as Craig pointed out, to advance organizational strategies. We have been doing that through promoting leadership and governance involvement, including our updated guidance documents to our conditions of participation in March of last year, and promoting the culture of patient safety surveys in the new patient safety structural measure. 2 is empowering the patient voice. We have always had ombudsman assistance for patients, but the new patient safety structural measure also includes questions on patient access to records and their ability to suggest correction, as well as encouraging the use of communication and resolution tools such as Candor. 3rd, health safety system by design, promoting high reliability organization principles in the patient safety structural measure. 4th is strengthening safety competencies, again through our quality improvement organization assistance in the new patient safety structural measure, asking about education and training programs for safety, such as team steps. And 5, participating in the Learning and Research Network. Although we're not a research organization, we do provide direct assistance for learning. We fully support ongoing learning health systems through our robust portfolio of measures in public reporting, which are the metrics used by most organizations across the country. And finally, although we do not fund research, we do account for over $1 trillion of healthcare spend, which we all must steward wisely to ensure the highest quality, highest equity, and safest care for all. We look forward to your engagement and your feedback. And with that, I guess I'm passing back to Jade and then to our colleagues at the CDC. Thank you.
Thank you, Dr. Schreiber. Next slide, please. Next, we would like to introduce another federal partner, Amanda Carnes, who's a communication specialist at the Centers for Disease Control and Prevention. Amanda, the floor is yours.
Hello, everyone. Thank you so much for the opportunity to present today. As noted, my name is Amanda, and I am the lead of CDC's Project Firstline. And today I'm going to be talking about how our approach to infection control education and training is helping to improve patient and workforce safety. Next slide. Born out of the pandemic, CDC responded to the gaps and challenges in infection control with Project Firstline, a national education and training collaborative that provides innovative and accessible infection control education for all frontline healthcare workers so they can protect their patients, their coworkers, and themselves from infectious disease threats in healthcare. Project Firstline offers educational resources in a variety of formats to meet the diverse learning needs and preferences of the healthcare workforce. Resources are designed to empower and enable healthcare workers to think critically about infection control using adult learning principles, education best practices, CDC recommendations, and the science that informs them. Project Firstline encourages all healthcare workers to take advantage of our free infection control training resources that were developed with healthcare workers, specifically for healthcare workers. Next slide. As a collaborative, Project Firstline brings together more than 80 academic, healthcare, and public health partners to reach a wide range of healthcare audiences and settings across the country. This includes 64 state, local, and territorial health departments, which are critical in our mission in reaching our audiences. Next slide. To reach our audience of the diverse healthcare workforce, we know we have to begin with formative and audience research to better understand who they are. We know that the more you know about your audience's unique needs, health literacy, cultural beliefs and practices, and preferred communication methods, the easier it will be to reach them. At Project Firstline, the primary purpose of our audience research is to identify exactly who our frontline healthcare workers are and how do we best reach them. For instance, we want to better understand how frontline healthcare workers feel about infection control practices, what channels are being used to reach them, and also we use our audience research to test specific creative executions brand concepts, and educational products and designs to see if they resonate and motivate our audience to effectively practice infection control. For us, we knew we need to conduct audience research to understand healthcare workers' lived realities to more effectively educate this population. And we continue to conduct formative research every year to ensure that we're reaching our audience effectively. Next slide. Through our formative research over the years, we've learned a lot about how healthcare workers felt or experienced traditional or existing infection control training and education. For instance, we learned that many felt formal training was generic, unengaging, inaccessible, and employed uncoordinated learning touchpoints that didn't support an ecosystem for effective learning opportunities. We also learned that training was perceived to be disconnected from their work and their lived experiences, and often didn't support their professional growth. For many, trainings often failed to acknowledge the why behind why they were being told a specific infection control guidance. We also found that some healthcare workers shared the belief that infection control could often be seen as a barrier to empathetic patient care, something that surprised us and highlighted a bit of the frustration many were feeling with current infection control guidelines being practiced. Next slide. From these findings, we developed an audience-based and equitable approach that actively tries to develop education and communication resources that engage frontline workers and respond to their communication preferences. Our approach listens to healthcare workers and appreciates the value of everyone on the front lines, no matter their role or their responsibility. Our approach also addresses equity and accessibility and aims to meet the needs and preferences of the diverse healthcare workforce as a whole. At the core of Project Firstline's approach, we realized that bandwidth continues to be low for all healthcare workers, so we offer tailored, bite-sized content that can be accessed and utilized during the workday. And we reach our audiences where they are through carefully selected channels and platforms with the information they need to practice infection control. Next slide. Informed by findings from our formative, we know that our content needs to be intentional and framed in ways that tap into intrinsic work-related motivations, teach the why as much as the what and the how, and use scenarios to ground content in lived experiences. Our approach is also grounded in plain language principles that balance communicating in tone that is scientifically accurate, actionable, and authoritative, while also being approachable and conversation in nature. Next slide. At Project Firstline, we work to communicate everything with a health equity lens. Using a health equity lens in communicating, planning, and developing means intentionally looking at the potential positive and negative impacts of proposed messages on everyone with the goal to be inclusive, avoid bias and stigmatization, and effectively reach intended audiences, ideally with input from those intended audiences. In order to do this, we follow health equity guiding principles when developing communication products and strategies, including to avoid perpetuating health inequities, to ensure information is culturally responsive, accessible, and available. And we strive to ensure that information is available in appropriate languages and formats. In addition, it's critical to address all people inclusively and respectively, which means we use person-first language. So instead of saying diabetic, we say people with diabetes. We avoid unintentional blaming. We use preferred terms for select population groups. We choose images carefully in order to represent the people who you're trying to reach, and we avoid stereotypes. Next slide. Here's an overview of the materials and resources we have available to healthcare workers free of charge. We have downloadable educational resources in the form of job aids, posters, and fact sheets that can be used in a variety of ways to share and reinforce important infection control information within a facility and among staff. We also have interactive, scenario-based tools that allow healthcare workers to test their infection control knowledge and gain valuable feedback in real time. These resources are accessible and mobile-friendly and can be completed in a few minutes. In addition, we have a variety of training resources that whether a facilitator has 5 minutes or 30 minutes, they can use and lead an effective infection control training. We have training toolkits to lead live or web-based training sessions. And we also have new micro-learn trainings to lead quick in-person guided discussions. Next slide. Since its inception, Project Firstline has been dedicated to reaching all healthcare workers equitably, and in working with partners, our resources are translated and adapted to be culturally and linguistically appropriate. For instance, we have a dedicated website for Spanish-speaking healthcare workers with over 75 translated resources. Our partners continue to help ensure our content and formats are diverse and inclusive. For instance, all of our trainings by health departments that Project Firstline has funded, 58% of them have been in languages other than English, 23% of those in Spanish. And our tribal health departments also adapt our materials to use imagery and language that is culturally relevant to their audience. And we have other partners who have translated our materials in English, Asian, and other languages. Next slide. This slide demonstrates the broad accomplishments of Project Firstline since we began in 2020. As of the end of July 2023, CDC had released over 300 education and training products, and our national and health department partners have released more than 600 products with the Project Firstline branding. As a collaborative, we've achieved more than 800 million media impressions across paid and organic platforms. We've hosted over 2,300 educational opportunities, reaching over 166,000 participants. And overall, feedback received shows that our Project Firstline educational offerings have been well received, with 92% on average reporting improved understanding of infection control topics, and 87% would recommend the trainings to others. Next slide. Here, I just wanted to kind of give an overview of our approach again. So really, we strive ourselves on realizing and understanding that one size does not fit all. It's important to develop products and communication methods that address a variety of formats to meet the learning needs and preferences of our audience. We also consider healthcare equity. Providing culturally and linguistically tailored education and training really helps healthcare workers understand and retain the information you're trying to present. We also utilize trusted partnership and communication channels. We know that CDC can't be the only voice, and our partners' voices are incredibly important in providing the information our audiences needs to effectively practice infection control. Next slide. And here's just a list of our resources that are available for all frontline healthcare workers. And then lastly, my last slide is just my email in case you have any questions. But thank you all for allowing me to present today.
No, thank you, Ms. Carnes. We are so grateful for your presentation and sharing these incredible resources. I think one of my key takeaways that I like to share with the group is, what you've heard today from 3 federal agencies is really just a smattering of the tools and resources that are available. And what is going to make the most difference is getting it into the hands of our frontline providers and engaging with them. And so we are requesting for each of you participating today that you take what you've heard today and share that with at least 2 colleagues and ask them to join us for our next call, which I'll get to in just a second. Next slide, please. We really want to make sure that these webinars and the work that we're doing is meeting the needs of the larger patient and workforce safety community. So we'd like for you to enter into the chat, what topics would you like to see featured as part of the National Action Alliance webinar series? And you might think about things that that you are learning or seeing as we reorganize ourselves coming out of the pandemic. These might be problematic areas. If you are one of the early adopters and you have done your self-assessment with your organization, there may be particular areas that are coming to light through that, but we want to be the most help to you. So if you could just take a few moments and enter into the chat some topics, we'll be sure to get some resources to you and highlight them on as part of our future webinar series. Next slide, please. Just want to say thank you for being with us, many of you spending your lunch hour with us. Announcing our next National Action Alliance monthly webinar is Understanding and Operationalizing the National Action Alliance, Advancing the Organizational Safety Strategies Using the National Action Plan Foundations. So if you have already done your self-assessment, this would be a really wonderful webinar to join. And if you have yet to do that, then you can learn how to best go about it. So registration is open and can be found on the National Action Alliance website. And we look forward to hearing from you again on May 21st from 12 noon to 1 p.m. Eastern Time. With that said, this concludes our webinar for today, and we look forward to seeing you again in May. Thank you.